Good afternoon. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thank you for joining me today for Facebook Live here from CGH. Today, I'm going to give you a brief update on particularly vaccination stuff, where we're at. And then I'm looking forward to my guest today is Dr. Marc Stees, dermatologist here at CGH, and fitting to have Dr. Stees on now as we go into the Memorial Day weekend and as the weather warms up and we get more sunshine on our faces. So I thought it was good timing to have him on. So looking forward to that. But before I get to Dr. Stees, let me just share a few things with you. I'm mainly going to focus on vaccination stuff today. So people that have been fully vaccinated, the vaccines have been working very well. For instance, some numbers, 2 people per million are dying from COVID if they have been fully vaccinated, or 1 in 500,000. That's pretty good odds. I mean, you feel bad for anyone, but that's really good odds for folks who have been fully vaccinated. And on May 17th, for the fully vaccinated public, the number they had there was 123 million people have been fully vaccinated on that date. At that point in time, 1,949 of those folks had been hospitalized or passed away. So obviously, that's 1 in 63,109. Once again, I mean, really good odds for folks who are fully vaccinated. So the vaccines have been very effective and proven to be a game changer. I will make mention, though, that of those people who have been hospitalized after being fully vaccinated, 79% of those people are over the age of 65, which makes sense because as we get older, our immune systems don't respond as well as immune systems of folks who are younger, which goes to why it's so nice now that we're at the 12 plus category, can begin getting vaccinated, because the more of those, and the vaccine for people who are in that age group is like almost like 100% effective, so far at least. So it's really helpful that we have more and more of those 12 plus younger folks getting vaccinated, not only for themselves, but also because the fewer of them that get sick, the fewer folks who expose those 65 plus crowd whose immune systems may not have taken quite as much of a robust response to the vaccine. That being said, though, vaccine tremendous in all age groups in terms of its effectiveness. I wanted to give you some information just about CGH and our vaccines, what's going on here. So it looks like right now we've fully vaccinated 5,837 people just here at CGH. Now, of course, the health department has done a large number too. 5,837 is about 10% of Whiteside County. This week, we're going to be giving 332 at the clinic, at the Ryberg, which is our mass vaccination site, and at least 76 plus at the main clinic. And as I mentioned last week, the main clinic, we have a walk-in vaccine on the second floor, and we have both Moderna and J&J vaccine there. So please take advantage of that if you or someone you know still wants to get vaccinated. In Illinois, vaccine number-wise, 66% of Illinoisans have had a first dose, and 49% have been fully vaccinated. So that's good. And I just would make a comment. I know that there are some folks who just aren't going to get this vaccine. They're just dead set against it. But there are a lot of folks who it hasn't been convenient so far for them with their work schedule, or they have some reluctance or hesitancy to get a vaccine. And I just encourage folks to think about this, and as you have conversations with those people, it's okay. I don't want anyone to feel like you feel shamed about having hesitancy or concerns. But it is really, when it boils down to it, a matter of balancing risk when you think about getting a vaccine, any vaccine. And I was just looking up a few things, and you think about risk of everyday life. So if you get a chance, maybe you don't want to do this, but Google risk of processed meat, diet soda, smoking, obesity, car crash, dying in a car crash. What I saw was 1 in 608 lifetime risk. And a dance party, they have data on that. If you go to a dance party, it's 1 in 100,000 people die at a dance party. Who would have known? So when we think in terms of vaccinations and the safety of them based upon the numbers we're seeing so far and how effective they are, wow, good deal. Good deal. I'm so glad that we have them. And speaking of being a good deal and working effectively, Matt, would you show us some information for this week about our numbers? So yeah, if you look at that, those are our Whiteside County numbers. On the left there are weekly cases, and the red is this week. The blue is the previous week, and the bottom part of that, bottom left of that, the red is previous 2 weeks. Excuse me, red is the last 2 weeks, and the blue is the previous 2 weeks to that. So you can see that it is in all age categories. We're making really good progress. So once again, the vaccine is working very nicely. And then you see our county numbers on the right there, which are really encouraging. And we continue to be, it's been great. We've been lower than the state average for the last few weeks, which is not how it has been. So that's really good. I'm really happy with that. And then one last thing that we tend to show most weeks is our arrow up or arrow down graph. And it'll come in just a second here. There we go. So yeah, we look in terms of natural immunity, which is code word for you've had COVID infection and or been vaccinated. And that is the positive thing that happens. And then the variance and then how we behave would pull the number of people get infected up. And right now the arrow is pointing strongly in the natural immunity plus vaccination camp, which I couldn't be happier with. So continue the good work for those of you who are watching. Encourage others to continue to get vaccinated because it's working. So I had one viewer question. What is the policy? This is before we started even. It was, what is the policy at CGH? Would you show that again, Rebecca? Thanks. What is the policy at the CGH clinic of requiring a patient to have a COVID test prior to a doctor's appointment? So I would say in general, we don't have a policy that a patient has to have a COVID test before a doctor's appointment. So anyone can show up and we ask them the questions, but they don't have to have a test. Now, where we are still doing this, asking for folks to make sure that everyone is safe when patients show up, is if someone has any symptom that might be suggestive of COVID, in those situations, in general, we have patients go either to our Ready Care or to our emergency department. And so in that bucket of patient, that's where we tend to send them. We are working through on the clinic side of things. I think we don't have a set what we're doing yet, but there are offices that are seeing some patients, but they're oftentimes saying, hey, have you had a negative test within the past week? If you have some sort of COVID-like symptoms. And then in that situation, then those offices will go ahead and see that patient. So I hope that clarifies that viewer question. Okay, we'll take other questions regarding that if you want during the course of our Facebook Live, but I want to get to Dr. Stees. So Dr. Stees, where are you?
Well, I'm in Dixon today, Dr. Bird.
Good to see you. I've known Dr. Stees for a few years.
At least 15.
Yeah.
16. Yeah.
Well, thanks for joining me. And I know I'm glad Dr. Stees is joining me because he had a pretty busy clinic this morning. He ran into me yesterday and said, I don't know. But I'm glad you made it. I'm glad it worked out. So
it did. Thank you. Yes.
Okay. So start with a non-medical or at least specific to skin question. So our viewers may not know this, but you're originally from Freeport. Did you go to Akron or FHS?
I went to Freeport High School. I'm a proud pretzel.
Ah, okay. All right. So what got a pretzel interested in going to medical school?
Well, it depends on how much time you have, but I guess I started in college as an engineering major, and actually a civil engineering major, and I didn't think that was my niche, and I ended up graduating with a degree in bioengineering or biomedical engineering. But looking back, I had a couple of mentors in my community that I always looked up to. And as my interests shifted, I thought that it was something that I would enjoy, and that's kind of what led me down that path. So,
Yeah. And how about dermatology? What kind of made you move in that direction?
I rotated through everything as we all do in medical school, and it always kind of intrigued me. It's a mixture. It's a cerebral specialty. There's a lot of complex problems that we deal with. I prescribe a lot of, I don't know if you would call it complex or dangerous medications for medical issues, and then also there's a pretty prominent surgical side to dermatology. So it was a nice mixture of both. And
Okay.
again, where I went to medical school, there was a great group of dermatologists there that ended up being great mentors to me and seeded my interest, and they're still great mentors to this day, and I'm thankful for that. So,
Yeah, that makes sense. Yeah, good. So I do want to segue though now into some skin cancer questions. So let's start with the one that people, the dreaded M word. So let's start with melanoma. Um, and melanoma, for those who are watching, that's the skin cancer that can spread, metastasize, and yeah, it can be life threatening if it goes too far. So can you talk a little bit about the ABCs of melanoma detection, Mark?
for sure, yeah. So the AB, that's actually A, B, C, D, E is what they have now, and those are sort of it's a nice, easy way to think about abnormal lesions on your skin. So the A stands for asymmetry, and how you define that. You take a lesion or spot on your skin, you draw a line down the middle of it, and if one half is different than the other, then it's considered asymmetric. B is for border irregularity. So if you look at, if it's not a smooth round border, if it has jagged edges, or they call it scalloped borders, where you'll have a little, maybe a wave to one side of a lesion, that's what you would call an irregular border. C is for color variegation. So often melanomas will have varying shades of brown, black, sometimes even blue or red if they've been growing for a while. Um, D is for diameter. That's a little less specific. The rule of thumb is anything over 6 millimeters in size. You should probably go back and look to see if it has any of the ABCs. And then the E that they've added, in the last 5 or 10 years, that relates to evolving, or that refers to evolving. So melanoma lesions, they're not static; they change over time. And oftentimes, what I'll have patients do is take a picture of a spot they may be worried about with their phone, because phones nowadays have such great cameras, and then set a timer on their phone to take another picture in 3 months and flip
Uh,
back and forth and see if they've noticed any changes or if the lesion has evolved at all.
yeah,
So that's kind of a way for someone to
yeah,
track a lesion.
that's good. So melanoma can occur anywhere in our bodies, but are there any, for men and women, any differences in where we tend to get melanomas?
Certainly the higher frequency locations are going to be the trunk and the lower legs, but at least for invasive melanoma, and it's not too much different in the sexes, but generally more common for women to get them on the legs, and men to get them on the torso, especially the back. But
Okay,
they also can occur on the head and neck as well, and
sure,
honestly anywhere. But
yeah. So in your clinical in the years you've been in practice, do you see any like trends where, like for melanomas, that patients don't seem to recognize that the ABCs kind of stuff that they don't recognize? Are there types of melanomas that they struggle to say, oh, this may be something abnormal?
there are there are rare occurrences of melanoma skin cancers that do not make pigment. Um, and so, yeah, I mean, I have had a handful of those come in where people really didn't know what they were, but kind of we'll talk about the other forms of common skin cancer, but one of my rules of thumb to patients is if you have something that doesn't heal up in, say, a month's time, then that's something you should take pause and pay attention to and perhaps get evaluated. Because common things like a cut or a scrape or a bug bite or a zit will heal up in a month's time. And so melanoma skin cancers that are presenting without any pigment will also sort of follow that general rule where they'll maybe scab up or bleed or they'll be evolving, changing. So
Yeah,
I'm not sure if I answered your question.
I think you did.
Yeah.
Yeah. And then getting just one other thing about melanoma. So what's the status of the incidence, detection, and treatment of melanoma in the U.S. these days?
Well, I mean, the incidence is definitely increasing, and that's probably attributed to a couple, a handful of things. People have more leisure time than they used to, so they spend more time outdoors. Um, People are living longer. A lot of time, it's a product of, the amount of sun exposure you get over your lifetime. And I think we as medical professionals are getting better at educating patients and also diagnosing the lesions. I have this really wonderful little tool. I
Mm,
use it all day, every day. If any of you watching have been my patients, it's an extension of me. It's called a dermatoscope, and I'm able to detect earlier lesions using this device. It gives you a view into the dermis, into the second layer of the skin, and you can see the pigmentary pattern of lesions much clearer and diagnose lesions earlier using it.
yeah.
So that contributes to the increased incidence as well. More of them are being diagnosed earlier.
Yeah. And for people that have like advanced melanoma, um, I am reading where there's some treatments that are much more helpful than they used to be.
Super exciting. When I first started practicing, it was very sad. There was very little hope if you had a melanoma that had spread. Um, and over the last 5 or 10 years, that has changed. I mean, don't get me wrong, many people still pass from it, but there are emerging therapies that have been very beneficial to people, prolong their life, reduce the amount of disease and problems they have with it. So
Yeah.
that's been really exciting, for
Yeah.
sure.
And one other thing I think dermatology has done a good job with is, if I remember right, the vast majority of folks that we detect melanoma in, you take it out and you have to do surveillance, but they go on and live their lives because it hasn't spread.
Exactly. Yes. I mean, the sooner you catch it, the better. So if you catch it early, uh, the treatment is surgical excision, usually just in the office under local anesthetic.
Yeah.
Um, and the decision on whether to the treatment decision depends on the characteristics of the melanoma at the time of biopsy, and that guides you. So if it's early and thin, then you can excise it in the office. If it is thicker or more advanced, patients may have to go have a lymph node checked in the area of the skin, the lymph node basin in the area that drains the area where the skin drains into, I guess. So
Yeah.
neck, armpits, groin area, for example.
Yeah, good. Let's talk about some other types of skin cancer, squamous cell and basal cell cancers. So, how can you tell the difference between these two types of skin cancer?
They often look very similar to each other, at least to the untrained eye.
Okay.
Um, Occasionally, squamous cell skin cancers can grow quickly and look somewhat like almost like a small volcano.
Yeah.
They'll almost rupture on the skin and have a central crater. Uh, but generally, they both, to the layperson, they'll show up as a bump that's usually reddish in color, that's enlarging, that will scab or bleed. Um, Usually they're painless. Occasionally, squamous cell skin cancers are painful, uh, but yeah, it's difficult to probably tell them apart sometimes to the untrained eye.
Right. Do they tend to metastasize like a melanoma would do?
Squamous cell skin cancer has that capability. The higher risk locations are the ear, lip, and scalp, and there's size dependent. You know, once it gets over 2 centimeters in size, which is not quite an inch, it is at higher risk for metastasis. And then there are other, you know, getting into the weeds of it, there are other microscopic characteristics that also can be higher risk for spread, generally locally to a lymph node
Okay.
is where they would spread at
Yeah.
first.
Yeah. Thanks. Yeah, and for our viewers, Dr. Stees was actually in practice for, I don't know, we were a decade maybe, and then,
11 years. 11 years.
yeah, yeah, and then decided to do some more training. So he went and did a fellowship doing something called Mohs surgery, and yeah, and now he's doing that here at CGH, which is pretty exciting. So can you talk, Dr. Stees, about what Mohs surgery is and what got you interested in doing this extra training?
Sure. So, you know, as first of all, Mohs surgery is a specialized technique where we do the skin cancer removal, and then we take that tissue to a lab that we have on site in the clinic, and we make microscope slides from that tissue while the patient waits. Usually takes, depending on the case, a half an hour to an hour, and I review those slides on site, and I can assess whether or not I've removed all the cancer with that first stage. If cancer has gone to an edge, I know precisely where that is because we keep it oriented with respect to the patient throughout the entire process. And I only have to go back and remove more skin where the cancer was present. And then we go back and forth and until we get all the cancer out. And as my practice evolved and I had more experience doing surgical procedures, found that I enjoyed them more. I found I had kind of reached a plateau as to where I felt like I was doing what was best for the patient as far as skin cancer removal goes, because um, you really shouldn't do any sort of complicated repairs like a skin flap or graft unless you've made sure you've gotten all of the cancer out. It's just not the proper thing to do for the patient. And so um, I wanted to be able to do that for my patients. And when you work without having that immediate margin control, is what the word would be. And then when you have it, you have this profound appreciation for what a luxury it really is to be able to do good work, honestly.
Yeah.
So,
Yeah. I don't think there's many folks around the area that do Mohs. Is there?
there's nobody who's done a fellowship there's nobody in Rockford. There was one fellowship trained person in the Quad Cities. I don't believe there's any fellowship trained Mohs surgeons in Peoria. And then, of course, when you get to the western suburbs,
Sure.
you find them there. But yeah, it's a
Yeah.
pretty large geographic area where there's no fellowship trained Mohs surgeons. There might be some dermatologists that do it without a fellowship, but I feel like the best work is done by people who've gone on to get that extra training.
Yeah.
Because you just never know what you're going to get into once
Right.
you start. And you need to have that experience to take care of complex things.
Yeah.
And so,
Yeah, I don't disagree with you, Mark, and it's just great that we have that here in the area for patients who need it. The process, how long does that take? Is it for a patient to have one layer taken off and then have you take a look and then look and see if you need to take another part of a layer off? What's the time frame for a typical Mohs procedure for a patient? Is there a range?
it varies, you know. So if it's a smaller lesion, it maybe takes 30 to 45 minutes to make the slides. And then And then, you know, usually I'll do some sort of repair or stitch up the patient, so to speak, you know. So depending on where they're at in the order, we start in the morning because we never know what the day will hold for any individual, and it's somewhat of a leapfrog. But on average, 2 to 3 hours. You know, if it's a really large lesion where I have to go back many times, I think my record here is 9 times.
Oh, wow.
Certainly, we were finishing them up at 5 o'clock at night. You know, I mean, that's a very long day for the patient. But again, you know, I give them a very high cure rate. And if something is that difficult, you don't want it to come back. You don't
No.
want to go through it a second time, you know, so,
Yeah.
but that's the exception, usually 2 to 3 hours.
Okay. Yeah. By the way, Deb, thanks for your comments. Deb, appreciate it.
Thank you.
You know, do you do this on squamous cells or is it just basal cells?
Basal cell, squamous cell are by far the most common. There are some rarer tumors, atypical fibrosarcoma, and one that I'll say DFSP. It's a spindle cell tumor, and then there's a handful of other rarer things you can use it for that I generally do not. But yeah, you mostly 95% are basal cell carcinoma and squamous cell carcinoma.
Okay. And just following up with that, Mark, I mean, I could see that if I'm a patient, I see the advantage of sparing as much skin as possible, so I don't have a big defect from this, and the ability to when you do close things up, that you feel comfortable that you've closed up only good tissue and not diseased tissue that's going to grow back. So I like that idea. But I guess the follow up to that is, are there any areas or times when you wouldn't do Mohs for a patient?
Sometimes if a lesion is so large, I'd have a hard time keeping them comfortable. And what I mean by that is, you know,
Yeah.
it just depends, and there's also some emerging evidence that, especially for large squamous cell carcinomas, some of those patients may benefit from having a lymph node checked. It's called the Sentinel lymph node examination. And that's just kind of evolved over the last, really year, as kind of maybe a direction where larger, more aggressive tumors, that may be where it's going for them. But I mean, but for the most part, I mean, most basal cell and squamous cell skin cancers are amenable to those, and I'll
Yeah.
tackle that. And that's the benefit of doing the fellowship, really. When you're at I was at the University of Wisconsin. It's a large referral center. I had over 1,000 cases that year as a fellow, and
Wow.
we do the removal and big stuff, small stuff, difficult places to work. You get that experience, and then you repair most of those as well. So it was a very worthwhile year for sure.
So whether you have a basal cell or squamous cell from the neck up or the neck down, they were still candidates for Mohs type of procedures.
Well, yeah, I would say probably almost 95% of my cases are head and neck.
Okay.
It would be wonderful to be able to do Mohs surgery on every lesion. However, where you don't need tissue sparing, it's probably I don't know, over treatment for a lot of them. Larger lesions on the trunk, or lesions that have recurred if they've been treated by another method and have come back, or lesions that are aggressive. Those are ones on the trunk trunk, arms, legs that we'll do Mohs surgery on. We do a lot of them on the hands because there's not much
skin.
The skin is very thin there, and you want to spare it. You don't have a lot of extra skin to pull it together if it needs a repair. So you want it, because with Mohs surgery, because of the way we process the tissue, I can take a much smaller margin than a standard way of removal. So it's very tissue sparing, and I still get a higher cure rate for those cancers because of the way we process the tissue.
Yeah.
And so I'm not sure I answered the question.
You did. I like it. Yeah, I didn't think about the back of the hand thing, but that's a good point. So, hey, by the way, thank you, Nancy. It sounds like Dr. I'm not surprised that Dr. Stees and his team did a really nice job in taking care of your whatever was going on with you. So,
Thank you.
yeah. Well, Dr. Stees, you probably have afternoon clinic too, don't you? Have more folks to help out with. So,
Right.
yeah, I appreciate you taking the time to pop in and answer a few questions. And yeah, it's been good information. And I'm sure those who are listening they're farther ahead in terms of their understanding of skin cancer than they were when they started. So, thank you for your time. Thank you for the work that you do, and glad to have you here on the show.
Thank you very much, Bill.
Yeah.
Thank you to everyone behind the scenes as well. Appreciate it.
Yep. Hey, until next week, we thank you for watching in. Oh, here we go. So Kimberly was asking, does testing happen each week, Dr. Bird, or how does it work? I'm wanting to get my J&J vaccine. Yeah, so I think the question is in terms of, does a vaccination happen every week? Actually, it happens every day. So at the main clinic on the second floor, there's signage for this. You can just ask when you get to the main clinic. But every day from about 8:30 to 4:30, we have a vaccine clinic, and we have J&J and Moderna there. So sure, yeah, come on down even today or tomorrow, and we can get you set up. So, okay, Brian's asking about immunity from natural versus the shot. I don't know for sure. I don't have a great answer for you, Brian. I'm glad you're out and you've recovered from COVID. At least so far, I'm reading that despite having an infection, that they still would recommend you get a shot. But I think we're still working that all out. And still, I saw something today about that we think immunity is lasting at least a year or so, maybe up to 2. And so, yeah, I don't know the answer to your question, and that's how it goes sometimes with COVID. There was another question that popped up. Marley asked, is there a place to report or research possible COVID-19 vaccine side effects? In a group of friends recently, I mentioned something that wasn't the only one with the experience. Not terribly serious, but it seems worth reporting. Yeah. I don't know, but I would think through the CDC and or the company, if you had like a Pfizer shot, that they would have a reporting arm that you could have on their website. I think our marketing folks will do a little research, and can we reach out to them, team, to this person with that answer that question if we find that? Maybe a thumbs up if we could do that. Okay, yes, Matt says yes. So thanks for the question. I'm pretty sure if you go either CDC or the company, that there'll be an opportunity to report side effects, and that would be your best option. But if we find something else, we'll let you know, and we can post that too for folks. And yeah, and that's a good point though that our viewer brings up, is that the reality for a lot of folks who get this shot, you're going to have some type of side effects. There's obviously some fevers, pain at the site of the injection, body aches, all those type of things that you just never know who the folks are going to have those kind of symptoms. But yeah, they definitely happen for folks. And if you take a little Tylenol or ibuprofen, it tends to knock those down. And most of those symptoms are gone within 24 to 48 hours. So, but yeah, that's part of the process for sure. But side effects wise, we'll get some more information if we can find some. Any other questions? It's good. Well, hey, as always, I thank you for taking the time to watch and listen, and we'll answer what we know, and what we don't know, we'll try our best to find some answers for and get back with you next week on. And yeah, until then, have a great week. Enjoy your Memorial Day weekend. Hope it's a good one for all those who are watching us. Share this with your friends, and see you next Thursday. Take care.